Good afternoon and welcome. My name is Fleming-McPherson and I'm a doctoral of nursing practice student at Azusa Pacific University who is conducting an evidence-based quality improvement project. My project goal will be to analyze the impact new nurse knowledge of shared governance has on perceived empowerment in their practice environment both before and after receiving the education. The PICO question I'm attempting to answer with this information is, for new graduate nurses, how does structured education on shared governance affect their perception of empowerment, as measured by the Index of Professional Nursing Governance Survey within their practice environment 1 month after the intervention? So let's get started. The objectives for today's learning are to define shared governance, the benefits, the governance style, describe guiding principles of shared governance, identify key elements of shared governance models, distinguish the relationship between shared governance and the magnet principles, and then differentiate what is Providence Health and Services shared governance structure currently. Dr. Porter O'Grady, who's the pioneer for shared governance, says that shared governance is a relevant and vital issue in the structuring of professional practice. It's based off guiding principles of partnership, equity, accountability, and ownership. The shared governance model framework allows frontline staff to be empowered to make accountability-based decisions regarding their practice environment so that they can deliver safe, quality patient care. To achieve these goals, there needs to be a paradigm shift in culture from a hierarchical model to one of shared decision-making. Shared governance is a framework which integrates nursing values and beliefs into practice to improve the professional practice environment. The American Nurse Association Code of Ethics supports nursing participation in professional practice models to provide structure for promotion of shared decision-making. As nurses increase their participation in shared governance, it has a direct impact on quality and safety of care, professional practice, research, and innovation. So how is it defined differently? The diversity of theoretical perspectives has resulted in a variety of contemporary definitions of shared governance. Dr. Robert Hess in 1998 describes governance as including the structure and process by which organizational participants direct, control, and regulate the many goal-oriented efforts of other members. O'Malley portrays shared governance as an accountability-based governance system that shares power, control, and decision-making with the professional nursing staff within a clinical decision-making framework. Dr. Porter O'Grady says that shared governance as a dynamic is a way of conceptualizing empowerment and building structures to support it, and embodies 4 principles: partnership, accountability, equity, and ownership. And Clavel in 2013 says shared governance is a system of rules and policies that serve to engage individuals and groups to participate in decision-making. The responsibility and accountability for decisions is shared by members of the group. All of these are powerful ways to define this vital component of a just culture by empowering and engaging the nursing workforce. Nursing empowerment, as defined by Lassinger, is one's ability to effectively motivate and mobilize self and others to accomplish positive outcomes in nursing practice and your work environment. Through empowerment, the nurses can motivate oneself and others to drive practice that improve outcomes. Commitment to consistently enhancing our knowledge base and utilizing evidence-based practices allows for positive changes in our professional role of the nurse, which is seen in the empirical outcomes of increased workplace satisfaction, nursing engagement, and improved patient outcomes. Much of the literature stated that empowerment has also been shown to be essential to the goals and outcomes of shared governance models. When nurses are empowered, they are inspired and motivated to make meaningful contributions to their professional practice, and in turn be recognized and valued by their peers and leaders. In 2007, Minochlevich shared an article in the Online Journal of Issues in Nursing that empowerment for nurses may consist of 3 components: a workplace that has the requisite structures to promote empowerment, a psychological belief in one's ability to be empowered, and acknowledgement that there is power in the relationships and caring that nurses provide. Nurses need to cultivate power in their practice. It is not something that comes innately. As power grows, nurses can raise their practice through influence. Lassinger states that one of the characteristics of a profession is that professionals have power over the practice of their discipline, which is often referred to as professional autonomy. Autonomy is reflected through one's ability to transform practice through knowledge. Therefore, a key element of empowerment is nurses' control over their practice. The ability to act according to one's knowledge and judgment is known as control over the content of nursing practice and is often synonymous with autonomy. Studies show engaged nurses are empowered, valued, inspired, involved, they deliver better quality care, they have decrease in workplace injuries, improvement in patient safety, and increased job satisfaction. According to Myers in 2013, nurses employed less than 6 months and those furthest from bedside care were the most engaged. Some of the contributors to disengagement from the bedside nurses were significant issues in employee empowerment, lack of involvement in their practice environment, and poor relationships with their nursing leadership. Engagement refers to the staff's commitment to the organization, which is evidenced by their happiness at work, sense of belonging, and their pride in what they do. Press Ganey is a company utilized by most hospitals in the United States for metrics that are related to patient experience. They state that 15 of every 100 nurses are disengaged, resulting in them being less productive. Involvement in local decision-making through a shared governance model allows nurses to make decisions regarding their professional practice area. Shared governance structure aligns the nurse leaders with the frontline staff to engage ownership and autonomy to use their voice so that they can make changes within their professional practice environments. So why is this important? The United States Census Bureau predicts that the elderly population will double by 2025. Care for these individuals, the majority of whom have comorbidity conditions, will put an increased demand on hospitals. One of the ways to combat these increased nurse needs is through new graduate residency programs. In 2011, the Institute of Medicine addressed the necessity of reducing high turnover rates by concentration on transition into practice programs. They indicated that organizations must retain their nurses through supportive processes from leadership. The consequences of failure to address the expertise in the nursing gap are likely to include increased rates of medical errors and concomitant negative health outcomes for millions of Americans who need an expert and healthy educated nursing workforce to deliver care. Healthy work environments directly impact nurse satisfaction and nurse retention, safety, patient satisfaction, and quality outcomes. Shared governance is a venue for change and decision-making by those that are positioned to make the changes and deliver the care. So let's look at some of the different types of shared governance styles. There's self-governance, participatory management, and shared governance. Within these descriptors, multiple variations exist for how shared governance is managed by individual organizations. The most popular framework utilizes the council model of care management, which allows nurse-run councils to develop and orchestrate nursing practice. Management's role in this model is typically supportive and facilitative, with point-of-care practitioners guiding and directing practice. Typically, the councils consist of evidence-based practice, clinical practice, recruitment and retention, and unit-based councils. And there's usually a governing council that integrates the structure at a nursing administrative level. In looking at the goals of self-governance, the staff determine goals without input from leaders. In participatory management, leaders request input from staff. Use of input is optional. And in shared governance, staff are given the responsibility, authority, and accountability for decisions. The use of input, how are we utilizing the input that we are getting? In self-governance, it can foster a we-they mindset. In participatory management, leaders are not required to use their staff input. And in shared governance, leadership and staff activities are interdependent. How are decisions made? In self-governance, all decisions made with no external input of guidance. versus participatory management, where final decisions lie with leadership, who may accept or reject staff's input. And in shared governance, leaders clearly articulate the guidelines for those decisions. Where are the leaders in all of this? In self-governance, there is no leader. In participatory management, it's very hierarchical. And in shared governance, it's servant leadership. And the decisions are made in participatory management, and centralized decision making occurs. And in shared governance, decentralized decision making occurs. So where do the accountabilities for shared decision making lie? Vicki George wrote a book in 2011, Peer Review in Nursing: Principles for Successful Practice. It outlines the importance of professional accountability and need for a peer review process. It's not about the tools, forms, or processes. It's about a fundamental belief in the role actualization of a professional. It's about nurses accepting professional accountability and autonomy in their practice. She goes on to share, one cannot practice autonomously without developing a measurement of accountability. The social and economic importance of assuring high-quality peer outcomes within a rapidly shifting healthcare system calls for nursing to demonstrate autonomy in their practice. Therefore, the autonomy forces the discipline to develop new measures of accountability, and one of the ways is in the form of peer review. Since the nurse by volume and by proximity is the closest person to the client, it's imperative that they be charged with developing peer review processes that keep the patient safe. Advocating for high-quality outcomes from all disciplines that could add to or harm the patient in the clinical setting is our fundamental role as a nurse. It's imperative that we nurses practice this high level of autonomy so we can facilitate the patient experience and achieve the best possible outcomes. This is a pictorial depiction of clinical practice accountabilities and management accountabilities, and so much of it lies in shared decision making, although each one may be assigned to the clinical practice environment or to management. 90% of all decisions need to occur at the point of care, but 10% of those decisions happen as shared decisions. Dr. Porter O'Grady's philosophy on shared governance is it focuses on 4 guiding principles that serve as the foundation and cornerstone of the concept. When one incorporates the 4 principles of shared governance into their team behavior, they create a professional work environment of empowerment. The key elements must occur at the point of care in order to deliver cost-efficient and quality care to our patients. The guiding principles are partnership, equity, accountability, and ownership. Let's take a look into each one. The guiding principle of partnership is developing collaboration and healthy partnerships among the healthcare team, which is essential to team building, relationship development, and strengthening professional practice. Each team member's role is important in helping the organization to meet its goals. This importance is further demonstrated when staff are included in practice decisions and process changes. Partnerships development can occur both internally and externally within the organization. The internal partnerships among healthcare team members are important not only to improve communication among the team, but also to deliver safe patient care. When we look at our community partnerships, they can assist to strategically align organizational goals, such as expanding services within a community or building stronger alliances with our partner hospitals. Partnering with public and private organizations can also further advance public policy, which is related to nursing practice. Equity within a shared governance structure focuses on all members of the team having an equal stake in the outcome of the care and quality that they provide. No one role is more important than the other in providing safe and efficient care, and each member has specific knowledge and skills that, when combined with those of the entire team, deliver quality to patients in the most efficient way. Collaboration and team effort are essential for healthcare members to achieve optimal outcomes. Dr. Porter O'Grady says equity is achieved when team members come prepared to work within their scope of practice and role within the organization to achieve an overall goal. Accountability is the core of shared governance. When all staff members achieve a clear understanding of their role and expectations and take responsibility for their actions and decisions, shared governance is achieved through accountability. It is usually delegated to a role by someone who has the power. In order to operationalize professional accountability, there must be autonomy, authority, and control over practice. Dr. Porter O'Grady states that autonomy is the professional's right to undertake specified actions. The authority occurs when the power is given to implement the action, and control is achieved during the ability to enforce the action in an ongoing and consistent manner. He goes on to share that when shared governance is done well, nurses have professional accountability within their role and usually convey their accountability in practice, quality, competence, research, as well as resource management. Nurses must be willing to own their work, processes, and decisions. In addition, we must be willing to be involved in the evaluation process of our peers on the expectations that are established by the organization's nursing profession. Ownership occurs when everyone is invested. When the success of an organization depends on how well each member of the healthcare team performs their jobs, that's when success will occur. Bates in 2004 described staff paying attention to detail and showing pride in their work as signs of ownership. Ownership is being responsible for the end product or outcome, whether good or bad. The individual goals become team goals because the goal of the team can't be achieved without each person skillfully performing his other roles and integrating his or her efforts. Recognizing individuals and teams for their accomplishments is essential by leadership to maintain the motivation and achievements of these goals. So why were you chosen for this D&P project? Understaffing, burnout, increased nursing demands, and poor patient safety are reasons why nurses are leaving the profession. The work environment is a strong influencer on a nurse's decision to stay or leave. As nurse leaders, it is our obligation to understand what motivates nurses to stay long-term within an organization in order to stabilize our future nursing workforce. 1/4 of the nursing workforce is changing each year, which equates to 25.3% current first-year turnover rate of nursing. Trepanier et al. In 2017 did a study that revealed when new graduate nurses are mentored in a supportive learning environment, they have less stress and anxiety. Investing in the residency programs has shown great benefits of perceptions they are valued, resulting in decreased turnover rates, increase in job satisfaction, workload satisfaction, improved clinical decision-making skills, and engagement in their professional practice. Understanding shared governance principles and how they are applied in Providence Health and Services will give you the tools to be involved in your work environment, share governance structures, and share ideas to improve your professional practice. As Hillel the Elder said, if not you, then who? Shared governance is a tool in the vision within nursing leadership that has been proven through the literature to be effective and drive excellent nursing outcomes. A practice environment with shared governance empowers nurses to become informal leaders within their work environment and the profession. So what's in it for me? Shared governance is a great model to implement so nurses feel they're empowered, they have a voice, they have autonomy, they have control over their practice, and they're happier within their work environments. No matter what model of shared governance is followed, staff involvement and decision-making in the practice that they do is a win-win for us all. So why Magnet, and how does it play into a shared governance structure? In 1983, McClure et al. Did a study of working environments of 40 hospitals that were described as leading the way in their workforce satisfaction and quality, creating an excellent work environment. Due to their ability to attract and retain their nursing workforce, they were given the title of a magnet hospital. These hospitals set the precedence for engagement and quality. In 1990, the American Nurses Association approved the Magnet Recognition Program, and the first hospital was awarded the Magnet designation in 1997 after completion of a pilot in 5 hospitals. The Commission on Magnet Recognition felt that it was important to review the 2008 Magnet Vision Statement to ensure they defined relevant goals that were prevalent for the future. They wanted to address the environment of care that was essential for exemplary professional practice, and be sure to expand to emphasize the importance of nurses leading globally. The dialogue brought the understanding of the need to create a new mission statement that concentrated on the importance of magnet organizations. The ANA published the new mission statement, which is the Magnet Recognition Program will continually elevate patient care around the world in an environment where nurses in collaboration with the interprofessional team flourish by setting the standard for excellence through leadership, scientific discovery, and dissemination and implementation of new knowledge. The American Nurses Credentialing Center describes magnet designation as the highest and most prestigious credential a healthcare organization can achieve for nursing excellence. According to Swihart and Porter O'Grady, some would consider it the Nobel Prize of Nursing Excellence in professional practice environments. So let's look at the components. In looking at the components of the magnet model, the ANCC took the characteristics of the forces of magnetism and grouped them into 5 components that represent the framework that distinguishes magnet organizations. The domains that comprise the magnet conceptual model are depicted in this figure, and they include structural empowerment, exemplary professional practice, new knowledge and innovations, and transformational leadership. At the center of the components is empirical outcomes, which is the true beacon for excellence for nursing. Let's take a look at each one individually. Transformational leadership. As healthcare experiences unprecedented change, the beliefs, values, and behaviors must be aligned to meet our future demands. Transformational leadership is a way for leaders to create a vision that inspires and influences clinical knowledge and strong professional nursing practice. Change requires transformation. Innovation is necessary to bring new ideas to be considered in the practice environment. Nurses at the point of care know what works well and what doesn't. As transformation leadership approach grows in organizations, these ideas become realities and drive new evidence-based practices. We must lead today, always looking ahead through strategic planning, visibility, and access to leadership. Continually advocate for the resources needed to drive decision-making to advance our nursing practice and promote change. We need to ensure that we have solid mentoring and leadership development programs so we have leaders for the future. What is structural empowerment? Although the term has been around for quite a while, Cantor developed a theory in 1993 of structural empowerment, which includes a discussion of organizational behavior and empowerment. According to his theory, empowerment is promoted in work environments that provide employees with access to information, resources, support, and the opportunity to learn and develop. Structural empowerment is the foundation within the magnet model. When leaders create an environment for innovation to thrive based on organizational values, excellent outcomes will follow. According to Clavel, O'Grady, and Drenkard, in 2013, empowering practice environments in magnet organizations afford nurses a greater opportunity to create positive changes through nurse participation in shared governance activities, which supports their practice, allows for professional development, and recognizes nurses for excellence so they feel valued. Understanding the needs within the community and reaching them where they live are also ways in which a strategic plan based on structural empowerment becomes successful for an organization. The ANCC says the true hallmark of a magnet organization stems from exemplary professional practice. Nurses are able to demonstrate skills and behaviors that are worthy of honor, respect, and admiration. Exemplary professional practice requires the creation of a professional practice model and a care delivery model for nursing practice, a comprehensive understanding of the role of the nurse, and the application of that role with patients, families, communities, and their interdisciplinary teams, as well as the application of new knowledge and evidence to achieve extraordinary results. Some examples of models and processes in exemplary professional practice are the voice of nursing, the relationship-based care? Do you have peer performance review? Are you able to self-schedule and do staffing? Are you asked to be involved in the budget? Are you involved in recruitment and retention? Do you help to make policies and review policies within your area of practice? And do you work within a culture of safety? For the clinical examples, scope of practice. Do you have nursing values as well as hospital values? Do you have autonomy in your nursing practice? Do you utilize both internal and external experts? Do you use ethical decision making, and do you have resources supported for that? And are you involved in the interdisciplinary plan of care with your colleagues? As both formal and informal leaders, we are tasked to design and redesign processes that are safe through the application of evidence-based practices if we are able to be successful into the future. These advancements need to be visible in the science of nursing. Organizations have a responsibility to advancing patient care by contributing to new knowledge, leading innovation to result in overall improvement for our patients, our staff, and our communities. We need to be able to differentiate between what is evidence-based practice, what is research that needs to be done, and where is the process improvement. We need to be able to ensure that we have an infrastructure that is able to support nursing and contribute to the collaborative research that is being done. Empirical outcomes answers the questions, what difference have we made? It focuses on the results and differences that can be demonstrated based on the application of sound structures and processes within our healthcare teams, organizations, and systems of care. It's essentially our report card of any magnet-recognized organization by demonstrating excellence and innovation. It measures outcomes of nurse satisfaction, patient and family satisfaction, and our quality metrics. We must use quality data to measure outcomes and demonstrate solutions to the problems within our healthcare systems. Empirical outcomes shows us the way. In summary, hospitals that use the magnet model components within a shared governance structure have an impact on their practice environment. Staff are more engaged. It increases clinical nurse engagement and participation in their shared decision making. They're more accountable. It increases their accountability and control over professional practice at both a unit and organizational level. It's supporting in their professional practice environment. And ultimately, it increases patient, nurse, and quality outcomes. So what is a professional practice model, and how does it work at Providence Health and Services? A professional practice model is a picture that describes how registered nurses work together and grow professionally. The ANCC describes a professional practice model as a schematic description of a theory, phenomenon, or system that depicts how nurses practice, collaborate, communicate, and develop professionally to provide the highest quality care for those served by their organization. As practice continues to evolve, our professional practice models are reevaluated and revised. The overarching conceptual framework involves nurses, nursing care, and our interprofessional care. The picture of the system, theory, or phenomenon to depict is outlined in our nursing practice, our collaboration, communication, and professional development. And how we illustrate the alignment and integration of nursing practice, we do that with our mission, our vision, our values, and our philosophy. The professional practice model for Providence Health and Services Southern California region, as shown here, was developed in 2012 and into 2013 by a team of nurses representing the full continuum of care. Their goal was to depict the nursing care philosophy and practices shared throughout the Southern California hospitals. The professional practice model is grounded in two complementary nursing theories. Jean Watson's philosophy of nursing, based on her theory of human caring, and Patricia Benner's novice to expert theory, based on her book, From Novice to Expert, Excellence and Power in Clinical Nursing Practice. The professional practice model depicts how nurses grow into nursing practice and how they communicate and relate to patients, families, communities, and the interdisciplinary team. Jean Watson's theory of human caring focuses on the transformative power of caring touch. Her theory, described in Jean Watson's philosophy of nursing, is composed of 10 curative factors: the formation of values, the importance of faith and hope in healing, sensitivity to one's own feelings as well as the patient's, promotion of helping, trusting relationships through clear, open communication, the ability to express positive and negative feelings in order to process behavior, use of a scientific method of problem solving for decision making, use of interpersonal teaching and learning, provision for a supportive, protective, and corrective mental, physical, sociocultural, and spiritual environment, ability to provide for human needs, and allowance for existential phenomenological forces. Benner's novice to expert theory proposes that the nursing practice advances through 5 levels of expertise through experience. A nurse begins his or her career as a detached observer and moves forward to become an involved performer that looks at the situation as a whole rather than at the individual parts. In her book From Novice to Expert, she suggests that theory is propelled forward through professional practice. This final project was a shared responsibility of leadership between the clinical nurses and leadership teams. The 5 components of the professional practice model are quality and excellence in nursing care, professional development and advancement, interprofessional collaboration, evidence-based practice, and shared leadership and empowerment. The components were carefully chosen to depict the essence of professionalism in nursing practice, with a focus on excellent quality outcomes in a safe working environment. Providence Health and Services value professional development and advancement and promote opportunities for nurses to grow through collaboration and competence. They encourage and reward their participation in academic progression, national certification, and ongoing continuing education programs. Interprofessional collaboration within this context is a necessary component to professional growth. Team members being valuable expert resources to the care of patients and families. And evidence-based practice by using the systematic study of actions and phenomenon relative to the practice of nursing. They can greatly enhance nursing practice and patient care outcomes. The shared governance structure at Providence Health and Services is a counselor model. It includes councils, committees, or task force that identify and promote best practices in nursing. The structure includes chairs and co-chairs and follows rules of order for meetings, agendas, and minutes. The committee or council includes a diverse group of staff members with varied opinions. Their meetings are held on a schedule that allows for in-person, phone, or video conference attendance and is accessible to all. At Holy Cross, the shared governance structure is a representation of unit-based councils. There's unit-based teams, Nurse Coordinating Council, Nurse Leadership Council, Nursing Quality Improvement Council, Nursing Professional Practice and Safety Council, Nursing Satisfaction and Recruitment and Retention Council, Research Council, and Night Shift Council. Providence Health and Services embodies a shared vision for shared governance. It's a continuum of shared decision-making, making decisions about nursing practice, preserving RN autonomy and authority, regulating nursing practice, accepting accountability, and ensuring empowering structures are developed that drive excellent outcomes in nurse satisfaction, patient satisfaction, and quality outcomes. And lastly is really a call to action and an awareness of your professional practice environment. And as you continue on your journey in nursing, how will you get involved in unit-based teams, councils, and committees to empower you to make a difference in the work that you do? I'd like you to watch this video with me, and then I'll open up the forum for any questions.